for the introduction. I just wanted to say kind of a few things before we begin is I always prefer my presentations to be interactive. So I do have like a couple of discussion questions embedded into this presentation. So if you feel comfortable enough, feel free to interact in the chat or unmute yourself if you would like. And then I also just want to acknowledge that we are going to be talking about suicide as the title kind of states. So if you do need to kind of take a time to step away, please do so. And as always, take care of yourself as this can be a sensitive topic for some people. So some language when talking about suicide, you might hear me use some of these kind of consider saying words throughout this presentation, but we want to avoid saying failed or unsuccessful suicide as well as successful suicide. And we want to use the terms suicide attempt or attempted suicide instead, because using terms such as successful or failed can kind of sensationalize suicide and imply that dying by suicide is something that can be achieved. And then we also want to avoid saying committed suicide. And we want to rather say died by suicide or took their own life. This is because using terms such as committed kind of associates suicide with a crime or a sin, which kind of contributes to the overall stigma around suicide and stigmatizes survivors of suicide loss, those being friends and family members as well. So yeah, we would rather say died by suicide or took their own life. And then so feel free to shout it out or type in the chat. But when you hear the term mental health, what comes to mind? And there's not necessarily any right or wrong answers here, but just kind of wanted to hear what everyone's thoughts are on the term mental health.
State of mind.
Yeah, so state of mind. I see feeling safe and secure. Great. Yeah, those are all things that definitely encompass our mental health. So mental health is kind of a state of well-being. Everyone has a mental health, and our mental health enables people and ourselves to cope with the stresses of everyday life. It helps us like kind of realize our abilities, helps us contribute to our community. And it's more than just the presence or the absence of a mental health condition. And it's experienced differently from one person to the next. So just kind of wanted to reiterate that mental health is a state of well-being that everyone has, and it can definitely fluctuate and ebb and flow as an individual does. So some mental health by the numbers, some kind of like quick statistics. In general, among US adults, 1 in 5 experience a mental health condition each year. And then among youth age 6 to 17, 1 in 6 experience a mental health condition each year. And then I wanted to include this little statistic here about youth in foster care specifically. And it says that youth in foster care experience a substance dependency at 2 to 5 times higher rates than youth that are not involved with the foster care system. And it's just kind of important to kind of reiterate that and mention it because substance use and mental health or suicidality have kind of a reinforcing relationship with each other, where substance use can worsen mental health outcomes, and someone's mental well-being can also worsen their substance use and kind of create a cyclical effect. And this last little statistic here says that 50% of all lifetime mental health conditions begin by age 14 and 75% begin by age 24. So this is just kind of important to recognize and understand as a caregiver, that many individuals will experience symptoms of a mental health condition fairly early on into their life. And then, so kind of another discussion question for you. Do you think that mental health conditions and suicidal ideation are related? And again, yeah, there are no right or wrong answers there. Okay, so we see usually but not always. And I think that is kind of a good answer there. And then you can go ahead and go to the next slide. Because yeah, so usually not, but not always. So yes, um, mental health conditions and suicidal ideation are related, but one does not necessarily have to have a diagnosis to die by suicide. So 54% of people who die by suicide do not actually have a diagnosed mental health condition. Sometimes suicidal crises can just result from life's challenging events. Um, some of those could be, grief and loneliness, social isolation, financial hardship and job loss, bullying, relationship issues, discrimination, kind of that sense of loss of purpose and feeling hopeless, as well as even natural disasters. So those can be kind of referred to as risk factors. And we'll get into risk factors in a little bit. So back to that kind of original discussion question, some of the truth to this statistic right here may imply that some of these individuals just haven't received mental health treatment yet. But it's kind of important to acknowledge both sides of the spectrum, to not assume that everyone who dies by suicide has a mental health condition, and to also not assume that everyone who has a mental health condition will consider suicide. So great answer there. It's a yes and no answer. And then so risk factors. So risk factors are things that generally may put someone at an increased risk for suicide, having thoughts of suicide, or potentially attempting suicide. So kind of on the individual level, some of those risk factors could be a previous suicide attempt, impulsive or aggressive tendencies, feeling like a burden to others, low self-esteem or self-worth. Some relationship risk factors could be the loss or lack thereof, having high conflict or violent relationships, a current or prior history of adverse childhood experiences, and kind of a lack of affirming relationships and communication. And then on the community and societal level, some of those risk factors could be a suicide cluster in the community, stigma associated with someone seeking help, and those help-seeking behaviors, reduced access to health care, and easy access to lethal means of suicide, which we'll get into later on in this presentation. And so one thing that I want to point out is that potentially not always, but youth in foster care could likely experience multiple of these risk factors for suicide. That doesn't necessarily imply that all youth will contemplate suicide or attempt suicide. However, due to the fact that youth in the foster care system experience a combination of multiple risk factors, they are at increased risk for suicide, and therefore they do exhibit higher rates of suicide compared to youth that are not involved in the foster care system. And so some of those statistics involved with youth suicide and youth in the foster care. Um, so youth in foster care are 2.5 times more likely to contemplate suicide than youth not in foster care, and they're 4 times more likely to attempt suicide. So that kind of just highlights some of the disparities there among youth in the foster care system. And then this last part, I could make a whole presentation about the disparities involved with suicide. But I just wanted to acknowledge that in recent years, rates for all youth have increased among Black youth, male and female, Hispanic and Asian females, and LGBTQ youth. So with LGBTQ youth, they have kind of always kind of experienced disparities within suicide, and there is research that suggests an association with the socio-political environment and high rates among LGBTQ youth. Among Black youth and Hispanic and Asian females, this has been historically for Black youth in particular, white youth have had higher rates than Black youth, but in recent years that has kind of been changing, whereas the rates in Black youth and young adults have been increasing, and there needs to be further research to understand why this might be occurring, and so that these communities can create programs that will prevent suicide within their communities that is designed and tailored for them and are applicable and useful within those communities. So then some of the protective factors for suicide. So similarly to risk factors, protective factors are things that will protect someone from suicide. So some of the protective factors on an individual level, that includes effective coping and problem-solving skills, reasons for living, a strong sense of cultural identity or belonging, a sense of purpose and proactive self-care, to name a few. And then on that relationship level, support from friends, family, and partners, healthy social connections, being a source of support for others and the community, and then maintaining healthy boundaries. And then, so on that community and society level, protective factors could be feeling connected to your school, to your community, to other social institutions, as well as having access to consistent and high quality health care, anti-discrimination policies, and reduced access to lethal means. So generally speaking, these are factors that will protect someone from suicide. However, we know suicide is a multifaceted issue, and someone could have a bunch of these protective factors, but could still consider suicide. And as well as vice versa, someone might not have a bunch of these protective factors and never consider suicide. So it really just highlights the complexity of suicide and what that entails. So then kind of another discussion question. So when you hear warning signs, what comes to mind? All right, so talking about not wanting to be here, yeah, I would definitely consider that to be a warning sign. Yep, Googling about suicide or death. So they could just be potentially Googling about the topic, or they could potentially be Googling, a means to do so or creating a plan. Yeah, those are all good examples of a warning sign. I also want to mention that another term for warning signs could be what we call invitations. And warning signs as invitations to ask about suicide. So now we'll kind of go to these invitations to ask about suicide. I was taught that in a training that I had attended, and I thought that I really liked the term invitations to ask about suicide over warning signs. I just felt like that was kind of a more call to action. Instead of me seeing warning signs, I'm seeing an invitation for me to reach out and ask if someone is considering suicide and potentially um, help them or connect them to resources or whatever that may be. So I really like that term, invitations. So some actions or kind of physical things that you could notice are giving away possessions, exhibiting kind of impulsive or reckless behavior that could look a lot of different ways, from drug or alcohol use to sexual behaviors to reckless driving behaviors, anything that might fall under that category, as well as kind of withdrawal or loss of interest, self-harm, which may be more of an obvious one, disturbed sleep or change or loss of appetite or weight, and then extreme behavior changes. So a common misconception is that these invitations or warning signs have to be kind of viewed as something negative. But really, this could look like kind of any extreme behavior change could be considered as a warning sign. So I guess a common example of maybe a quote unquote more like positive warning sign would be if someone who is usually like very shy or quiet, and then all of a sudden they're kind of chatting with everyone in the room and being like very social. That's an extreme behavior change. So that potentially could be an invitation to ask about suicide if that is very much like out of their norm. And then some of the words, so some of the things that someone might say that could be an invitation will be, it could range from all of my problems will end soon. A very common one that we hear among youth is I want to go to sleep and never wake up. Some other ones, now I know what they were going through, or I'm a burden to everyone. Those are some common ones as well. All right, so now we can kind of get into preventing suicide among youth and kind of some steps that we can take to do that. So I always like to reiterate that you do not have to be a clinician to prevent suicide. Um, Everyone can play a role in preventing suicide, and it truly does take everyone doing what they can to accomplish that goal. All right, so we talked about some of those protective factors for suicide. So how do we strengthen them? How do we strengthen those protective factors? We can model coping skills and expressing emotions. So having a conversation with your child about what coping skills are and how they can use them to either calm down or recharge themselves or kind of take control of their emotions. As caregivers, you want to be strong and kind of put on a brave face sometimes in front of your child. But it's important to kind of find the balance of acknowledging and expressing your emotions so your children can do the same and let you know when they might be feeling some of those more negative emotions. And then building supports and connectedness. So if your child has few close relationships, try building their network through extracurricular or online activities, community groups, and increasing family interactions if they're positive. Those are all ways to build some more supports. And then strengthening their sense of purpose. So it could also be that building supports could also help strengthen one's sense of purpose, as well as providing youth creative and stress relieving outlets through creative expression, physical exercise, sports, adequate sleep. Another strong protective factor is for an individual is being a source of support for others. So that could include, volunteering for others. It may not come across as inviting to a teen, but there's a lot of research that backs up that being a source of support for others and volunteering is a strong protective factor for suicide. And then empowering their self-autonomy. So when we think about youth in foster care specifically, this is something that they might not have been able to experience yet. So this is a very important one, and parents and caregivers can encourage self-autonomy by providing kind of age-appropriate opportunities for children to kind of make independent choices and decisions, brainstorm solutions together as a unit, and then offer guidance when needed, and then provide explanations for your rules and your expectations, and then minimize judgment and control. Just kind of giving a child more of their own autonomy back to them. And then, of course, mental health support is incredibly important. Um, Providing mental health support from like licensed professionals can make a big difference in the outcomes for a child experiencing suicidal thinking or depression or other mental health concerns. Obviously, each child will have probably different needs that could include therapy, medication, a combination of approaches as well, or other effective strategies. So all of these protective factors will build resilience in children. And then you want to also limit access to lethal means. So that involves a lethal means to suicide. So that could be a firearm, it could be unused medication, it could be like chemicals or something in the home. So we want to limit access to lethal means. And we'll talk more in depth about that. But basically, we want to extend the amount of time from when thoughts of suicide occur and when someone is able to access that lethal means of suicide. So we want to limit that access and extend the amount of time for when those thoughts of suicide can potentially subside. And then one thing that I will mention is among youth, the most like common lethal means of suicide is a firearm, which is a kind of recent change in recent years. It used to not be firearm, so obviously youth are not legally able to purchase a firearm. So it is usually, I mean, it is always them accessing someone else's firearm. So really limiting access to lethal means is just general safety, but also to reduce the risk of suicide as well. And then, so many youth in foster care, unfortunately, do not get screened for suicide risk. This is a big gap in research. And then universal suicide risk assessment screenings, they need to be implemented across all settings that youth may come in contact with. There are some suggestions and recommendations for strategies on how to implement this, but it needs to be embedded in all forms of healthcare and child welfare settings that a child may come in contact with. And perspectives from youth in foster care, behavioral health providers, primary care doctors, social workers, foster parents, etc. All of those perspectives need to be included to better understand how this could be achieved. And I won't get into all the logistics of how professionals within the foster care system are often overworked. But there are some studies that kind of recommend training case managers as they might come in contact the most with youth, but there's a lot of barriers to implementing that, and unfortunately, it doesn't seem like there's one perfect solution, but it is something that needs to be addressed for sure. So, um, many youth in foster care are not getting screened for suicide. So how could I potentially screen my child, screen another child for suicide? There's an app called the Columbia Protocol, and I highly recommend using this app. It's an app that will show you the Columbia Suicide Severity Rating Scale, or the CSSRS. And this app can be utilized to assess like someone's relative risk for suicide. The app is very efficient and user-friendly, and it's designed basically for any individual to use. And you do not necessarily have to be a clinician or a provider to use this app and then screen for suicide risk. It walks you pretty much through every step and question. Then at the end, it will kind of rate an individual's overall risk for suicide and even suggest some potential next steps. And then also, I know if you allow them to view your location, it will provide a local mental health resource that you could reach out to, as well as 988. And then usually that mental health resource, I think, is a behavioral health crisis center that is closest to you, but it may not always be that local crisis center. It could be another one. All right. And then so before you screen, um, this one may seem a little easier said than done, but you have to get comfortable talking about suicide. So a common misconception that some people have is that by bringing up suicide, you might put that thought into someone's head, but there's no data that really supports that. If someone's already thinking about suicide, then they're already thinking about it, and it is best to address that. Um, Obviously, we all wish that a child would come to a trusted adult if they're having these feelings, but often that's not always the case, and sometimes you just need someone to ask in order for you to open up about that. And many times youth won't open up about these feelings for due to a multitude of reasons, but they might not want their caregivers to overreact. There's obviously stigma surrounding the topic. There could be some cultural factors, or they might have had a prior negative experience with the mental health system. So always important to ask, especially if you think that they might be considering it. And then ideation versus intention. So this is something that's kind of important to recognize as well. So ideation is kind of having thoughts of suicide, and it could range from, I wish I were dead, to more like detailed plans about how they might die. And then suicidal ideation is quite common actually for someone to experience at some point in time of their life. And again, it can kind of range in the level of severity. And then there are some studies that show that 2 to 3% of individuals who experience suicidal ideation will actually go on to die by suicide. However, that doesn't mean that suicidal ideation should be ignored. And then with intent, intent is having that clear desire and plan to die by suicide, which may be kind of accompanied by some specific steps to prepare, such as obtaining a means to do so. And then one last thing I want to acknowledge is that ideation and intent can be fluid. So someone who is only thinking about suicide, they may develop the intent to do so, and then again, vice versa. All right. So now what if I'm worried that my child might be having thoughts of suicide, or what if my child tells me they're having thoughts of suicide? So these can kind of be, intimidating topics. We don't want to think about the people that we care about considering that. Um, but if you think that your child might be having thoughts of suicide, it's important to explore invitations to ask, and you can kind of list those out in your conversation. So I've been noticing X, Y, and Z. And then next thing you want to do is you want to be direct as possible. You don't want to leave any room for interpretation. You want to say, are you having thoughts of suicide? And you'd rather say that than, asking, are you thinking about hurting yourself? Because then it's not as clear and it leaves room for interpretation. So then if your child tells you they're having thoughts of suicide or they confide in you after you ask, um, sometimes people always second guess what to do in that moment. I love like the go-to to thank them for telling you this. And that could look like, thank you for feeling comfortable enough to share this with me. That kind of makes them feel more comfortable in this moment, in a very vulnerable moment, um, talking about a stigmatizing topic as well. It's going to make them more likely to confide in you. And then my cat is joining us. Everyone say hi to Leo. But it basically just shows them that you care about them, and you're able to kind of build some trust and rapport between the two of you by doing that. And then so one other thing is if they've mentioned that they're having thoughts of suicide, it's important to ask if they've thought about how um, and how they might die by suicide. This will be kind of informative for you as their caregiver to know how urgent or severe the situation is. And it will allow you to reduce access to lethal means, which we're going to talk about in a little bit. Um, and when you're developing that safety plan. And then, so listen to their story. So hearing someone's story is arguably kind of like the most important section of it all. Oftentimes when someone has like revealed that they're having suicidal thoughts or behaviors, we want to immediately go into safety planning. We want to immediately provide them solutions, or resources. That's kind of our natural instinct. We want to immediately help. But often individuals just want someone to hear their story. By hearing someone's story, we can kind of listen to a turning point or what we can call a sign of life. Um, and we want to support that sign of life. So sometimes these signs are more obvious, such as, what was I thinking? I don't want to kill myself. But often they are a lot less obvious, such as something like, all I want to do right now is die. So this could imply that there are some times when they don't necessarily feel that way. And it provides you, as their caregiver, an opportunity to kind of look more into that. And then another thing that I'll mention is if you can't necessarily think of a turning point that they've mentioned or you haven't heard one, you're not sure, sometimes a turning point could just be the fact that they're talking to you about their feelings and they're being open about what they're going through, and they might want some help with those feelings. And then whenever a turning point might be identified, sorry, my cat is trying to be a guest presenter right now. Um, but yeah, so whenever a turning point might be identified, it's important to repeat that back to the individual, so they can hear it and process it and kind of realize that they did say that. So that could look like, so I heard that all you want to do right now is die. Does that mean that there are other times that you don't want to do that? Um, and yeah, by doing so, there's kind of like a good chance that that individual hasn't realized that what they said initially, um, and they're repeating that back to them, will likely make their safety plan kind of more successful, as they might be able to identify a reason for living or at least wanting to kind of stay safe for now. All right, so kind of what to do next. You want to identify if an immediate intervention is needed. So if someone is actively trying to hurt themselves, you want to call 911. That could be if someone has like taken pills or is just, trying to cause themselves or others physical harm. Always best to call 911 in that moment. If someone has a plan in place, but they might not be in kind of immediate danger, it's recommended to call the MCRT or the Mobile Crisis Response Team. And we have a couple slides on MCRT later. But if you feel like they're kind of generally safe or unsure about their safety, you can always call the MCRT or 988 to be safe. So our uh, and then if you are kind of able, if they're not as at risk or it's not as an immediate intervention needed, you can always kind of develop a safety plan as not, or create a safety plan as needed. And if that immediate intervention is not needed. And then one other thing I just kind of want to mention is, as caregivers, you cannot be expected to like act as licensed mental health professionals. So if your child has expressed this to you, it's always best to call 988. You shouldn't be required to make any decisions kind of by yourself or without a licensed professional, and you shouldn't necessarily have to carry the weight of that on your shoulders alone. Sorry, I think we're good now. My cat was having he needed attention. So, all right. So now that we've talked about kind of that safety plan, we want to now try to create that. And so there's kind of like 6 general steps to a safety plan. And those include recognizing personal warning signs, utilizing internal coping strategies, identifying people or places that provide distraction, reaching out for social support, accessing professional services, and creating a protective environment. So typically safety plans are used after thoughts of suicide have occurred, or someone has expressed that they're having thoughts of suicide. However, I feel like safety plans should be used as more of a preventative tool for anyone before a suicidal crisis occurs. Thoughts of suicide can often be very quick and abrupt. Unlike many people think that maybe sometimes these thoughts have been lingering, which that can be the case. But sometimes once someone has decided and created a plan, there can be very little time for when they try to attempt that plan. And so I like to think of this as, when I think of it as a preventative tool, I kind of like to think of it as like a hurricane evacuation plan or a fire drill. I used to live in Florida for about like 5 or 6 years. And when hurricanes come, if you don't have a plan in place, your mind is going everywhere. I'm trying to think, okay, I got to pack this, this, and that. What supplies do I need? Oh crap, I have to take my cat. I got to pack up all of his things. Do I go and evacuate to Miami, down south? Do I go up to Georgia? All of these things. And it's hard for you to think when there's so much chaos kind of going on at once, if you don't already have that plan in place. So yeah, like I said, there's not much research as them for safety plans to be used as a preventative tool. But in terms of an intervention, they have been shown to reduce suicidal behaviors by around 45%. So it's kind of believed that if they're used as a preventative tool, then they might be even more effective in that sense. And then one last thing about safety plans is they have to be unique and realistic to that individual. So example, are the warning signs actually something that I do? Are these coping strategies, something that helps me? And then are the people that I can ask for help going to be available to me 24 hours a day or whenever I may need them? Or is at least one person going to be available? And then I'll also say this is just an example of a 988 safety plan. There's a lot of different versions of them out there. Some of them actually provide examples of certain warning signs and coping strategies. And I find that a lot helpful, especially with youth, so that they can, if they're not able to identify necessarily what are some of the things that they do, or what are some of the things that help them off the top of their head. So by no means endorsing the 90-day safety plan. I just wanted to show a simpler version of it, but acknowledge that there's a lot of them out there. And then so you've heard me reference kind of the 988 suicide and crisis hotline. So that 988 number is a 24/7 free and confidential text, chat, or call suicide and crisis hotline. Um, and then so you can kind of press one if you're a veteran or have served in the military. You can press two for Spanish speaking, and press three if you're an LGBTQ plus person under the age of 25. And so what 98 will do is they'll basically kind of assist you with anything that you may need. They can connect you to other resources such as your local mobile crisis response team if it was needed. And then they're basically just there to talk and be there for basically whatever you may need. One thing that I love to mention about 98 is that you don't need to be in a crisis to call or text. You can simply reach out to them to ask for resources, ask for advice on how to talk to a friend or your child. And then they'll also even help you fill out a safety plan, which what we were just talking about. And then so now how does 98, come into play with mobile crisis response? Is you can call 988, and if a mobile crisis response team is needed, they can connect you and get a response team out to wherever you are. So the purpose of that is kind of an alternative to calling the police, and instead kind of calling a licensed professional who is more adequately trained to respond to these types of situations. So this alternative is kind of meant the overall goal is meant to get an individual the help and resources and tools that they need, instead of potentially, going to jail or just automatically sent to an inpatient facility. But yeah, so based on these professionals' kind of expertise, they will be able to assess someone's suicide risk and determine if it's needed to go to a behavioral health crisis center, or if it's needed just to refer them to outpatient services, or develop a safety plan. And then I included the Missouri crisis line. I think MOCAR stands for Missouri Crisis Access Response System or something like that. And then the Kansas one has two. One's kind of like a more local one, and then one is for family 20 or younger. But I also say if you do not have these saved in your phone, you can always contact 98 and they'll be able to assist you with that. And then lastly, I just wanted to include some resources in here. So there's obviously the 98 Lifeline website, the American Foundation for Suicide Prevention, the Trevor Project, which does a lot of research within the LGBTQ young youth and young adult population, Active Minds, and then NAMI. There's some resources there. And there's also, I found a guide to trauma for caregivers, which is very applicable to youth in the foster care system.